Welcome to another episode of Diabetes Care on Air, a new and different way to bring the research in diabetes care to life. Today, we are featuring the content of the April 2023 issue. My name is Dr. Mike Rickles from the University of Pennsylvania.
And I'm Alice Chang from the University of Toronto. Once again, we will be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment. So without further ado, let's dive right in.
In the April 2023 issue of Diabetes Care, one of the feature articles is entitled Polygenic Scores Help Reduce Racial Disparities in Predictive Accuracy of Automated Type 1 Diabetes Classification Algorithms. I'm delighted we have with us the article's first author, Dr. Aaron Deutsch, and the article's senior author, Dr. Miriam Udler. Aaron is a research fellow in medicine, and Miriam is an assistant professor of medicine, both at Harvard Medical School and the Massachusetts General Hospital and Research Institute. Welcome, Aaron and Miriam. I'm so glad you could join us.
Thank you for having us.
Yeah, thanks so much. We're excited to be here.
Congratulations to you both and your co-authors on this feature article. Your study incorporates the use of polygenic risk scores for type 1 diabetes together with an already established automated algorithm that uses the electronic medical record to identify individuals as having type 1 diabetes. As clinicians, we are all too familiar with inaccurate diagnosis coding, for example, in the electronic medical record or EMR. Can you please walk us through how the automated algorithm identifies an individual as having type 1 diabetes, as well as how the accuracy of the algorithm is affected by an individual's self-reported race?
Certainly. So in this paper, we applied an automated algorithm, which was initially developed in the eMERGE consortium, which is a large national network that studies electronic medical records and genomics. This algorithm is very straightforward, and it uses data that's easily accessible in the EMR. So first, individuals are included if they have any ICD code for type 1 diabetes in their medical record, as well as any prescription for insulin. Then individuals are excluded if they have any prescriptions for type 2 diabetes medications, or if they have any ICD code for other conditions such as malignant cancer, cystic fibrosis, or drug-induced diabetes. So for this project, we manually reviewed the medical records in order to confirm the diagnosis of type 1 diabetes. We calculated the positive predictive value of this automated algorithm. So that is, we asked what percentage of individuals who were selected by the algorithm were actually confirmed to have type 1 diabetes. And we found that the answer varied according to the individual's self-reported race. So for instance, in the Mass General Brigham Biobank, the positive predictive value of the automated type 1 diabetes algorithm was 71% for white participants, but only 55% for Black participants.
And so as I understand as well, this misclassification as type 1 diabetes, presuming those individuals having type 2 diabetes or potentially another form of diabetes, and occurring more often in those of Black or other non-white ancestry. And so this is where the polygenic risk score comes in, correct? So you incorporated the polygenic risk score for type 1 diabetes into this algorithm and improved the positive predictive value for identifying individuals as having type 1 diabetes close to 100% now for both self-reported white and non-white individuals. Can you please take us through how a polygenic risk score is calculated and how that might differ for those of white and non-white ancestry?
Absolutely. And what you said was correct. So polygenic scores provide an estimate of a person's genetic risk for a disease. So they combine together the effects of multiple common genetic variants across the whole genome. For type 1 diabetes, most of the genetic risks comes from the HLA or human leukocyte antigen region on chromosome 6. And these genes are critical to regulation of the immune system, and we know that they vary a lot across world populations. So in our paper, we used two different scores that have been published by other researchers. One was developed in population of European ancestry, and the other in a population of African ancestry. And they're not yet scores developed for other specific ancestries, but hopefully will come in the future. And we wanted to use the ancestry-specific polygenic scores that best matched our study population whenever possible, because this improves the predictive ability of the scores.
That's great. And what about genetically inferred ancestry. So your article also looks at this, and can you explain to us what is meant by genetically inferred ancestry and how that might help to identify individuals more accurately as having type 1 diabetes than relying on an individual's self-reported race?
Sure. So it's important to note that race is a social construct and it doesn't have a biologic basis. In our study, we also applied computational methods where we used the individual's genomic data in order to infer continental level ancestry groups. So these are labels such as African or East Asian or European and so on. And while there may be some correlation, these groupings are distinct from those labels that are applied based on self-identified race. So when we did this and we classified individuals according to their genetically inferred ancestry, we found that the automated type 1 diabetes algorithm had a higher positive predictive value for those with European genetic ancestry compared to those with other ancestry. And similar to our previous findings, when we added polygenic scores, this was very effective at improving the positive predictive value of the algorithm.
Great. And so now, what about negative predictive value? So your article acknowledges a limitation in that by increasing the positive predictive value of correctly classifying someone as having type 1 diabetes, that comes at a cost of lower sensitivity, meaning some individuals with type 1 diabetes may now be missed or may incorrectly be treated as having type 2 diabetes. And as you mentioned already, the clinical algorithm used excludes individuals prescribed type 2 diabetes medications. And we all know that this might include those who've been misdiagnosed as having type 2 diabetes who have type 1, or could be individuals with type 1 diabetes prescribed these medications off-label, as is increasingly common in clinical practice. So how big of a problem is this for classification, and what might be done to address these issues in the design of future algorithms?
Sure. So it is certainly true that for any classification algorithm, there's going to be a trade-off between sensitivity and specificity. And in this paper, it wasn't really feasible to calculate the negative predictive value of the algorithm, because in order to do that, we would have needed to manually review thousands of medical records by reviewing everyone who was not classified as having type 1 diabetes. But nevertheless, it is true that this algorithm will miss some patients who do, in fact, have type 1 diabetes. For instance, as you alluded to, patients with type 1 diabetes who are prescribed GLP-1 receptor agonists. So a future version of this algorithm could potentially allow certain medications to be classified as either type 1 or type 2 diabetes medications, and hopefully that would help to mitigate some of the issues that you raised.
Terrific. And how close do you think we are to seeing the use of polygenic risk scores incorporated in making the diagnosis of type 1 or type 2 diabetes in clinical practice?
So there's already a polygenic score for type 1 diabetes offered clinically in the United Kingdom through University of Exeter. But in the United States, the test is not yet clinically available. But I do suspect that it will become available in the not too distant future. I think it's important to remember that non-genetic tests are still the most informative measures that we have for determining a person's diabetes subtype. So for example, islet autoantibodies and C-peptide levels can be very useful. But there are certainly situations when it's still unclear, even when you have results for autoantibodies and C-peptide, it can still be unclear what type of diabetes a person has. And that's when there may be a real good clinical use for a type 1 diabetes polygenic score. So one thing to recognize is that there's still barriers that exist now to implementing these scores in practice. So first, the polygenic scores are constantly being updated as more genetic data becomes available. And as a result, they're becoming more and more accurate, but that means that we also need to be able to update the scores that we provide over time. And then additionally, there's implementation challenges for a clinical lab to generate and report polygenic scores. So there's even now, essentially a field of research devoted to determining how best to provide clinical reports for polygenic scores and start to be able to have clinical implementation. And so an example of one of these challenges that we mentioned earlier is that you ideally want a score to be best matched to a person's genetic ancestry. And in practice, that can be very challenging to implement. But all this being said, so there's certainly work that needs to be done before we see these scores, I think, available to be ordered by providers in the United States. But it's a really exciting space to watch. And I think, we are hopeful that they eventually will become available.
And in terms of cost, moving towards, say, the incorporation of determining genetic ancestry as well as polygenic risk scores using the latest information available, this would require then potentially also reanalyzing individuals who, as more information becomes available, and if they were genotyped years ago, there may be necessity to reevaluate them. And how does that factor into the implementation piece? Will there be a one-time shot, or is this something that's going to have to be continuously evaluated?
That's a great question. One benefit of genetic data is that you can measure it once in a person's lifetime and you have it. So at least the actual tests can be done once, but the interpretation may need to be updated over time.
Terrific. Well, that's certainly, I'm sure, important for keeping a limit on the costs. And finally, do you have any additional takeaway messages for readers?
Yes, well, overall, we think this is a great proof of concept, and it demonstrates how we can use polygenic scores to refine the diagnosis of type 1 diabetes, and in doing so, to reduce a racial disparity that we found in the diagnosis of type 1 diabetes. Importantly, more work is needed in order to understand why this disparity exists in the first place. And, on the subject of polygenic scores, as we had discussed earlier, we used polygenic scores that were derived specifically from either European ancestry or African ancestry cohorts. But ideally, as we mentioned, a polygenic score should include genetic information from a wide, diverse set of participants that would hopefully maximize predictive power across all populations. And in fact, we and others are undergoing efforts to develop that type of score as well.
That's really terrific. Doctors Aaron Deutsch and Miriam Udler, I really appreciate your taking the time to share your expertise with us. I sure hope to see soon genetic approaches incorporated in the diagnosis of diabetes that can aid clinicians in correctly classifying an individual's diabetes type from the outset of their disease, and especially for those from underrepresented groups that more often experience misclassification in our current diabetes practice. Thank you both and our listeners, who I encourage to access the full article in the April issue of Diabetes Care.
One of the feature articles from the April 2023 issue of Diabetes Care is titled Structural Racism as an Upstream Social Determinant of Diabetes Outcomes, a Scoping Review. I'm very happy to be joined today by the lead author, Dr. Leonard Egede, a professor of medicine and the inaugural Milwaukee Community Chair in Health Equity Research at the Medical College of Wisconsin. Welcome, Leonard, and thank you so much for doing this.
Oh, thank you so much. Really excited to be here and able to share information about the study that we did.
Excellent. Thank you. So first of all, congratulations to you and your colleagues for this feature article. Your scoping review is one of the first to summarize the evidence for structural racism as antecedent to the social determinants of diabetes outcomes in the United States. Now, to help us gain a better understanding of what you found, I'm going to start with what may seem like a very basic question, but I think a very necessary one. What exactly is structural racism?
Okay, so there are several definitions of structural racism, but the definition we tend to use is one that defines structural racism as a totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable systems. And so from an overarching standpoint, you have structural inequalities, which are differences that are tied to income, poverty, and all of that. And then when that inequality is focused on a racial group, then we use the word structural racism as a way to do that. So that's kind of a way to understand what that really means.
Okay, very good. Thank you for that. So what was the inspiration to conduct this scoping review, and what were you hoping to accomplish?
So, I've been doing this work now for over 20 years. And one of the things we've done health equity research over time. And the longer I've been in this space, we're beginning to find that a lot of the things we're dealing with downstream are really tied to things that are upstream. So most of us are using the word upstream now to talk about these ideas of structural factors. And so as we started doing more work, especially after the death of George Floyd, and we began the pandemic and all the challenges there, we began to ask the question in diabetes, where most of us work, what do we even know about these upstream factors? And so we decided that it made sense to actually begin to explore, because there's been several systematic reviews around social determinants. And we wanted to ask the question, beyond social determinants, upstream, what would they look like? And so we decided it made sense to actually do some studies to look at what do we know and what is the evidence for structural racism and its impact on diabetes.
So, my next question then is probably a pretty big one, given the scope of work that you and your group accomplished. So, what were some of the key findings then from this scoping review?
So one thing that's really important is that we didn't want to reinvent the wheel. So we actually took the WHO framework for social determinants, which interestingly already has structural factors. So what we wanted to do was to ask the question using an established framework where you have social determinants as downstream and structural factors as upstream. We wanted to identify what's already been done in the field. And the first thing we found was there's very little data on structural racism, very few studies in terms of what has actually been done. But what we did find is that within those few studies that have actually looked at the structural factors, there was significant impact on things in terms of clinical outcomes. So we found association with poor A1C, poor blood pressure, lower quality of life, lifestyle, diet and physical activity, and even standards of care. And then we even found higher mortality and years of life lost for adults with diabetes. So these factors are, even though there are very few studies, they actually, the studies that exist demonstrate that structural racism has a negative impact on health and health outcomes.
Wow. So, given what you and your group found, what do you want the readers and listeners to take away from this review? And I'm going to add another question to this. As you know, the readership and people who listen for diabetes care really come from all around the world. This specific scoping review was done for the United States. Are there lessons that could be applied outside of the United States?
So I'll take the first part of that question, which is that I think the key message we want people to recognize is that while we've done work on social determinants of health, we need to move beyond social determinants of health, social risk, and really look at upstream factors. And that structural racism, structural inequalities are upstream. And these things that are tied to power, resources, and things that really need to begin to change if we're going to improve outcomes for diabetes. So I think that's the first part of the takeaway, that structural racism, structural inequalities are antecedent to social determinants of health. The second part of this is that, while in the US, race is a key factor, in the rest of the world, a lot of times it's all tied to poverty. And so when we use the word structural inequalities, the same issues that are the underlying framework is structural inequalities. Structural racism is one form of structural inequality. So for the rest of the world, it's really important for people to recognize that these issues are consistent. So even though we focused on the US, if you actually did this study in other parts of the world, you're going to find similar issues tied to structural inequality. So I think there's a lot of work to be done as we begin to navigate this process to understand how does this apply to the rest of the world.
So I guess there's a lot of opportunity for reflection to look upstream, as you said, right? Not just look at the social determinants of health, but what may have led to those things happening and the structural inequalities. And it sounds like from a power differential that probably ends up being created by these structural inequalities. And finally, I'm going to ask you, and again, I think this is a big question then, what are your recommendations then for future work in this area?
I think the first thing we need to do is we need more rigorous research, right? So what we did was a scoping review. And the reason why it was a scoping review was we really didn't have enough studies to do a full systematic review. So what we need now are more rigorous research that actually evaluate structural racism, structural factors, structural inequalities, and other aspects of diabetes care. So that's going to be number one. And I think we need to move beyond just focusing on social determinants and really asking what leads to these social factors. The second thing we need to look at policies, because if we want to change these structural factors, the reason why they're structural is because they're usually tied to laws, they're usually tied to policies. So we need policy strategies and policy modifications to actually understand, one, policy evaluation, but then also changing some of those policies. Third, we need to look at pathways. How do these things come around? What are the mechanisms? What are the levers we can actually address? So if we understand the pathways, what are the sequence of events that lead to some of these effects, then we can actually identify areas to intervene. The fourth thing is we need interventions. I think most of us that have been in this field for a while, we've heard a lot about social determinants, and we're now asking the question, now what next? What kind of interventions do we need to put in place so that we don't have to talk about social determinants 10 years from now? How do we actually begin to put things in measures in place to ensure there's some level of equity across the board for people with diabetes? And then the last thing is we need to actually have a mechanism for tracking and monitoring over time. what you don't track doesn't change. And so we need to find ways to build this into our processes to ask the question, are there differences across income, across race, across certain subgroups? And what are these upstream factors, and have mechanisms in place and maybe even reporting of how these things are actually being monitored and have a way to actually track that. And I think diabetes care really can be a champion for this by actually beginning to publish more articles in this area, but then also maybe begin to include that as part of the annual updates that comes out every year from diabetes care, maybe building some areas about policy and some conversations about some of these structural factors.
Fantastic. Thank you very much, Dr. Leonard Egede, for sharing your expertise with us today and for helping us to better understand the relationship between structural racism and social determinants of diabetes outcomes in the United States. I certainly learned a lot listening to you today. And I think one thing that really struck me is what you said towards the end is 10 years from now, we do not want to be having the same conversation of let's understand more. Let's spend these 10 years, yes, understanding more, as you said, with more research, more in-depth research, but then also trying to fix / alter, modify the issues and see changes being made. So that was very powerful. And thank you very much for your contributions. And I encourage the listeners to read the full article in the April issue of Diabetes Care. So let's move on now to our Diabetes Care Rapid Exchange, where Mike and I get to chat about some articles we found of interest in this issue. I had a particularly tough time narrowing the list down this month. How about you, Mike?
Same here, Alice. Given how tough it was this month, let's give ourselves a little more leeway and talk about a few more articles. Deal?
Yeah, I think it's a great idea, Mike. When you can't choose one, you buy them all, right? Maybe not the best philosophy when I'm shopping, but it works well here. So why don't you go first, Mike?
Thanks, Alice. I'll start us off with an article that you asked me about addressing exercise in type 1 diabetes, which is often avoided by our patients in part due to fear of hypoglycemia. This article comes from Dr. Mike Riddell from York University in Toronto and colleagues. And by full disclosure, one of those colleagues includes me. And this provides primary results from the Type 1 Diabetes and Exercise Initiative, or T1-DEXI for short. T1-DEXI was a real-world study of at-home exercise that involved almost 500 individuals with type 1 diabetes. And each person was randomly assigned to complete structured aerobic, interval, or resistance exercise at least 6 times during a 4-week period. And during that 4-week period, they had continuous glucose, heart rate, and activity monitoring. They also had collection of their insulin delivery data and food intake that surrounded exercise events. And the primary result was that there were greater declines in glucose seen during exercise that was aerobic, followed by interval activity, and then finally resistance activity. And interestingly, similar declines in glucose that were activity dependent were seen regardless of whether individuals use closed loop, standard pump, or multiple daily injections for their insulin delivery. And most important, I think, is that the time spent in a normal glucose range was increased in participants from on average 70% to 76% for the 24 hours following all types of study exercise when compared to days when the individuals did not participate in any physical activity. And there was only a very modest increase in time spent with hypoglycemia. And so it seems participating in regular structured physical activity should help more individuals with type 1 diabetes achieve target levels of glycemia without markedly increasing their risk for experiencing any clinically significant hypoglycemia.
Well, congratulations to you and your colleagues on this excellent clinically relevant study. And once again, showing that our advice from mom was always right? Exercise is ultimately good for us. And this also gives us practical information to give to people living with type 1 diabetes who want to exercise. And it's great. So thank you, Mike. I guess you, Mike, and the other Mike for this study. Now, along the same theme, I really enjoyed reading about the use of mini-dose, ready-to-use liquid glucagon to prevent exercise-associated hypoglycemia in adults with type 1 diabetes. Dr. Ronnie Aronson and colleagues in Toronto conducted a 12-week outpatient study of 45 individuals living with type 1 diabetes. They were randomized to one of 3 arms: 50% reduction in insulin pump basal insulin infusion rate plus 150 micrograms of glucagon, or Another arm was reduction in pump basal rate and placebo. Or the third arm was 150 micrograms of glucagon alone. Participants did their usual moderate to high intensity aerobic exercise for 30 to 75 minutes in real world settings. And after a total of 795 exercise sessions, level 1 hypoglycemia on self monitoring blood glucose was lower in both glucagon arms compared to placebo. So, just a reminder, the two glucagon arms either had a reduction in basal rate or did not. Of note, the CGM metrics of time in range, time below range, and time above range did not significantly differ, and consumed grams of exercise carbs seemed lower with glucagon, but not statistically significantly different. So, maybe a potential strategy in the future for those who want to avoid extra exercise carbs.
Indeed, Alice, use of a mini-dose glucagon strategy may be particularly helpful prior to aerobic exercise, where the largest declines in glucose were observed in the T1-DEXY study. And also for people who are often engaged in aerobic activity to help with weight management and are certainly looking for an alternative to consuming empty sugar calories in order to get through their exercise activity. Now, turning to type 2 diabetes, there's an article by Dr. Mary Rooney from Johns Hopkins University in Baltimore and colleagues that investigates whether the plasma proteome can predict incident diabetes. In this study, the authors used samples collected from an almost 9,000 participants from the atherosclerosis risk and community studies and identified 47 plasma proteins that were predictive of incident diabetes, many of which were involved in inflammation and lipid metabolism pathways, and 3 with causal effects. Validation of these biomarkers could have a major impact on the application of this novel approach to better informing future interventions designed at type 2 diabetes prevention.
Yeah, all of these proteome type studies are quite interesting, and I think it's getting us closer and closer to true precision medicine and trying to predict things for the future. So, something to certainly watch out for. And staying on the theme of type 2 diabetes, I'm actually going to switch and talk about automated insulin delivery. Now, in the type 1 diabetes space, automated insulin delivery is well established at this point, although continues to be underused globally for sure. However, efficacy in type 2 diabetes is not as well studied. Dr. Georgia Davis from Emory University in Atlanta and colleagues conducted a feasibility study using the Omnipod 5 system in 24 adults with type 2 diabetes who were previously on either basal alone or basal bolus regimens. They completed 2 weeks of CGM data collection with their standard therapy, then switched to 8 weeks of automated insulin delivery. Now, those who were on basal alone were in manual mode for 2 weeks, then started the automated insulin delivery. Investigators decided what to do with their other antihyperglycemic therapies. Now, the mean age was 61 years of age with a baseline A1C of 9.4%. Percent time with elevated glucose, so greater than or equal to 250 milligrams per deciliter or 13.9 millimoles per liter, decreased with AID by 16.9%. Time in range increased by 21.9%, and A1C decreased by 1.3%. There was no significant change in total daily insulin or BMI. This to me is definitely food for thought, as I have to admit I had not really considered automated insulin delivery for type 2 diabetes before, and I especially like that they even selected those who were just on basal alone, so maybe I ought to rethink what I've been doing.
Yeah, I agree, Alice. I think we all need to reconsider insulin pump therapy as options for our patients with insulin-dependent type 2 diabetes, particularly now that pumps are available with automated insulin delivery features. And this might be especially important as well for those individuals with lean type 2 diabetes that has previously been associated with greater defects in beta cell function than that observed in obese type 2 diabetes. And in the present issue, we have a study from Taiwo Adesoba and Dr. Claire Brown from the University of Arkansas for Medical Sciences in Little Rock that examine trends in the prevalence of lean diabetes among more than 2.5 million adults in the United States who responded to the behavioral risk factor surveillance system between the years of 2015 to 2020. The authors found that the prevalence of diabetes is increasing among lean adults, with no significant change among overweight and obese adults. While more work is needed to better understand the mechanisms underlying this trend, Importantly, this increase in lean diabetes was most significant in Black and Hispanic populations and in females. Thus, the authors suggest deciding to screen for diabetes in adults should not be based on BMI criteria alone, but should also consider race, ethnicity, and sex.
Another good one. Thanks, Mike. I'm going to now talk a bit about eye exams and when we actually start using them or asking for them, I should say. So, the ADA standards of care recommend that a dilated eye exam should be conducted within 5 years after onset of type 1 diabetes, whereas it's recommended at the time of type 2 diabetes diagnosis. Now, this next article by Dr. John Malone from the University of South Florida and colleagues may help inform this recommendation. They determined that individuals who had early diabetic retinopathy, defined as onset prior to 5 years of type 1 diabetes diagnosis, had an increased risk of subsequent proliferative diabetic retinopathy, even after adjusting for A1C, age, duration of type 1 diabetes, sex, blood pressure, heart rate, use of ACE inhibitors, ACR, and EGFR, with a hazard ratio of 1.47. Therefore, identification of early onset diabetic retinopathy may influence prognosis and prompt us to be that much more diligent with the care of those individuals. And I think this is quite relevant because, from a Canadian perspective, for example, our guidelines recommend the first eye exam to take place 5 years after diagnosis of type 1 diabetes. So perhaps we ought to be revisiting that recommendation.
Yes, Alice. And I think the current conceptual staging of type 1 diabetes as progressing from autoimmunity through dysglycemia prior to the development of overt clinical diabetes should help provide a rationale that in some cases, individuals with type 1 diabetes may have been experiencing a prolonged period of exposure to elevated blood glucose before their diagnosis, similar to what is presumed to be occurring for type 2 diabetes. This issue contains another interesting article utilizing proteomic analysis, and in this case for predicting type 1 diabetes. Liliana Bakanaska from the University of Bristol and colleagues conducted proteomic profiling on twins concordant and discordant for type 1 diabetes and validated results using cohorts at risk and at diagnosis of type 1 diabetes, as well as type 2 diabetes controls. The authors found differences in levels of pancreatic exocrine enzymes between discordant twin pairs with lower levels of trypsinogen in twins with type 1 diabetes in recently diagnosed cases and in relatives at increased risk for progression to type 1 diabetes. What is most striking is that this exocrine-endocrine pancreas interaction can be identified before the onset of clinical disease, and so may contribute to improve risk stratification of autoantibody positive individuals for future progression to overt diabetes.
Something else to certainly watch to help us predict whom we could potentially help. So that's great. Thank you, Mike. Now, the last one I'm going to raise is a sobering one. Dr. Beju Shah and colleagues at the University of Toronto looked at the impact of income on cardiovascular hospitalizations among people with diabetes between 1995 and 2019 in Ontario, Canada, which is the province that I happen to live in. Now, they studied nearly 1.7 million people with diabetes. The good news is that the rate of acute myocardial infarction declined throughout the 25-year study period, with the rate in 2019 being less than half the rate it was in 1995, which is great news. Rates of stroke, heart failure, and amputation also went down over time. Again, great news. On the surface, though, it looked like hospitalization rates have stabilized over the 2010s. However, a deeper look revealed a concerning income disparity. The wealthier patients continued to have declining rates over the decade, but the lower income patients increased over the decade. So another sobering reminder that we continue to underserve those who need us the most. So although on the surface things looked really great and we're all doing a great job and the news is very positive, I think the deeper dive realizes that there is in fact significant disparity based on income.
Sobering indeed, and certainly important to bolster efforts in implementation science that really needs to get underway for our population with diabetes and make sure that advances in interventions and care really extend across the population and particularly those who are most vulnerable. Well, Alice, this brings us to the end of another podcast of Diabetes Care on Air. I want to send out a special thanks to our guests this month, Drs. Deutsch, Udler, and Egede, for sharing their insights with us.
And a reminder to everyone to submit their original art for consideration to be included as future cover art for Diabetes Care. And a big thank you to all of you for tuning in to this episode. We welcome your comments and feedback, and don't forget to subscribe and follow this series and get notifications when a new episode comes out. Thank you all for listening.